Good afternoon, respected delegates. Myself Dr. Ankita. I am going to present on the topic effect of clear corneal arcuate incisions for the correction of astigmatism using Alcon-Varian nomogram. 40% of patients undergoing cataract surgery have astigmatism up to 1 diopter and 70% have more than 0.5 diopter. So to tackle this low to moderate astigmatism, we have few options. Toric IOL and femtosecond laser assisted arcuate keratotomy are a bit expensive. The limbal relaxing incision needs a diamond plate, which is again expensive. The opposite clear corneal incision is a slightly unpredictable outcome. So we are left with two options. One is steepest meridian clear corneal incision, another is paired clear corneal arcuate incision. There are some studies which show a better result with a paired incision in comparison to a single incision. So the purpose of my study is to evaluate the efficacy of paired clear corneal arcuate incisions for the correction of mild to moderate corneal astigmatism during phacoemulsification using Alcon-Varian nomogram and compare the results with the demographically matched control group. This was a retrospective study from January to June 2024. Inclusion criteria was expected postoperative refraction with an astigmatism between 0.5 to 1.5 diopter and central corneal thickness between 470 to 550. The exclusion criteria was keratometry values more than 48 diopter and any corneal surface epithelial defect and posterior segment consideration.
That's
why I was like,
your moderators, who is judging this next session?
Height and arc length in the study group. In this, the incision was given up to 90% depth of the cornea between 7 to 8 mm diameter circles centered over the corneal vortex. We divided the study group into two groups based on the central corneal thickness. In patients having more than 500 micron thickness, we used a 600 micron guarded knife, and in patients with less than 500, we used a 550 micron guarded knife. The keratometry was recorded preoperatively and at 1 and 6 weeks postoperatively. The uncorrected visual acuity, best corrected visual acuity and acceptance were recorded at 1 week and 6 weeks follow-up. So coming to results, we studied the demographic data of both the groups like gender, age, CCT and preoperative astigmatism, and both of them were similar in both the groups. In the study group, the preoperative astigmatism less than 0.5 was 2.7%, which increased to 70% at 6 weeks postoperatively, but in the control group it was only 15.8%. This is the box and whisker pattern which shows a decreasing trend of astigmatism in the study group. In comparison, in the control group it remains almost similar. So we could make 52% of our patients in the study group happy with no spectacle for a distance, but in the control group it was 21%. The uncorrected visual acuity of 6/6 was there in 48% of our patients by 6 weeks post-op. In comparison, only 8% in the control group. The median astigmatism in the study group, it decreased from 0.86 to 0.44 at first week and again to 0.41 in the 6 weeks, but in the control group it remained almost similar. We again divided both the study population into two groups depending on the CCT, but they gave us a similar result showing that central corneal thickness does not affect the outcome of arcuate incisions. I could find two studies similar to our study. So in our there is also similar decrease in the K values post-operatively. The sample in our study the K value was 0.99, but in Fall et al. And Yep et al. It was a higher K value. In our study at 6 weeks the decrease was 54%, in Fall et al. It was 37% and in Yep et al. It was 52%. The sample size in these studies were very less compared to our study, which had a 375 sample size, and our study compares with a demographically similar group which was not present in these studies. So in conclusion, a significant number of patients have preoperative astigmatism but cannot afford its correction. A paired arcuate clear corneal incision with a simple guarded knife using nomogram in Varian markerless imaging system is a cost-effective method of correcting the astigmatism and giving emetopic vision to more than 85% of the patients. These are my references. Thank you.
So can you, earlier there used to be the section, now we are giving temporal, depending on this, which side, suppose the vertical is steep,
Yes, sir.
Where you will give the incision?
So we have to give on the steepest meridian.
Steepest meridian. The knife used was diamond knife or any knife to
So
keep the cut?
in R we used a specific knife by Mani,
Acha, there is a
which
specific.
gives the diamond knife is actually costly. It is like 25.
Okay,
to
when we used to
30,000.
be radial keratotomy,
Yes,
there
yes.
we used to do a.
So this is only 600 or 650, and it can be used in 5 to 7 cases.
Sure.